Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. One of the more interesting presentations coming out of ESMO 2018 in terms of clinical implications is actually the late results of a trial that's already been presented and published previously. Dr. Roy Herbst presented the long-term results of the KEYNOTE-010 trial that randomized previously treated patients with advanced non-small cell lung cancer and who had tumors positive for PD-L1 expression at a 1% threshold or higher to receive either pembrolizumab at one of two doses, 2 or 10 milligrams per kilogram IV every 3 weeks, given up to 2 years or 35 treatments, compared to docetaxel every 3 weeks until progression. The data that were shown featured the updated overall survival results with an additional 30 months of follow-up compared to the prior publication of the trial. As you can see on the left side of the slide, the results for patients with tumor PD-L1 of 1% or greater showed a hazard ratio for overall survival of 0.69, highly significant. Median overall survival 11.8 months versus 8.4 months with docetaxel, and 3-year overall survival 23% versus 11%, favoring the pembrolizumab. And the results were pooled across the 2 doses of pembrolizumab, which between themselves did not differ significantly. For the patients with PD-L1 of 50% or greater, the differences were even more stark, with a hazard ratio for overall survival of 0.53, very highly significant, median overall survival 16.9 versus 8.2 months, and a 3-year overall survival of 35% versus 13% with docetaxel. Really remarkable considering that this is therapy in the second line or later setting, and we have more than a third of patients alive 3 years out. And these are not particularly selected. Now, another focus of the presentation were the outcomes for the subgroup of 79 patients who had completed 2 years of pembrolizumab. In that group, 75 of these 79, or 95%, had achieved a complete or partial response by RECIST criteria, and among them 48 patients, or nearly 2/3, had an ongoing response even after discontinuing pembrolizumab, some well over a year after, with a median duration of response not yet reached. Median overall survival was also not reached in this population, but the Kaplan-Meier estimate of the 3-year overall survival was approximately 99%. Now, in that group who had completed 2 years of pembrolizumab, 25 patients, or just under a third, 32%, demonstrated progressing disease subsequently. And of the 14 who were re-challenged with pembrolizumab at progression, 6, or 43%, had a second response that was a partial response in all of these cases, as assessed by independent central review. These results are really very interesting, and in many ways they contrast the results of the Checkmate 153 trial that was presented by Dr. David Spiegel at ESMO 2017. The schema for that trial is shown here. This is not a particularly selected population. These are patients with advanced non-small cell previously treated, no required PD-L1 level for expression. And they received nivolumab for a year, and the patients who did not demonstrate progression at that time and did not have prohibitive toxicities were then randomized to either continue nivolumab without any break or stop after a year. And the results that were so striking showed this major difference in progression-free survival, hazard ratio 0.42, favoring continued therapy without stopping at a year, and a trend toward improved overall survival in that group. Now, interestingly, in that Checkmate 153 trial, when they looked at different subgroups in a PFS subgroup analysis, the patients who had high PD-L1 had the greatest benefit for continued therapy. So this is interesting to me to see that it's not as if having high PD-L1, which you'd think is associated with the best chance of a prolonged and profound result, would protect you and allow you to stay on therapy for longer without necessarily needing it. Here, based on Checkmate 153, it looks like the patients who had high PD-L1 are extremely dependent on being on ongoing therapy. And yet, in the KEYNOTE-010 trial, you see that patients with good, deep responses, these 95% of patients who were on the pembro for up to 2 years having a response, were able, in many cases, to sustain these good results without progression well beyond the time they stop it. Now, what we also saw from Checkmate 153 was a benefit with repeat treatment, this re-challenge idea. And even though in Checkmate 153 we didn't get response results, we do see from the swimmer's plot that there are a lot of patients who are going on and on for many months without progressing, presumably, while they continue on nivolumab after having subsequently progressed. So I would say that these results really changed my view of the field. I came back from ESMO 2017 really impressed by the results of Checkmate 153 that led me to be very disinclined to discontinue immunotherapy in my patients, even those who were benefiting for well beyond a year. Now, those results from Checkmate 153 still stand, but we have these results with very long follow-up from KEYNOTE-010, which was with pembrolizumab, not nivolumab, and gave 2 years of therapy, but really show that many of these patients can do very well without remaining on pembrolizumab indefinitely, and maybe 2 years is significantly better than 1 year. Maybe the results with pembrolizumab are just simply different from nivolumab, but at the end of the day, these results, I think, provide good supporting evidence to strongly consider discontinuing therapy, at least by the time you get patients out to 2 years if they're doing well. And I would also feel a little more confident about discontinuing it in patients who are having escalating toxicity issues over the course of prolonged treatment with immunotherapy. So I welcome your thoughts on this. I think there's still much more to learn, but I came away from this presentation really with a view that it has changed my perspective on how to treat these patients who are doing well for a long period of time on immunotherapy. I hope you'll like, comment, and subscribe. I welcome your thoughts and comments.